Welcome to The Spine Guy. I'm Dr. Brian Sue, a fellowship-trained spine surgeon in Marin, California. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. Today we'll be talking about a treatment for cervical myelopathy, which is treatment for spinal cord compression called a laminectomy and fusion. I briefly reviewed all the different surgical options. This is specifically only talking about laminectomy and fusion. So the goal of surgery is the laminectomy, which is going to the back of the cervical spine. So this is the neck. There's a front of the neck and back. So this is a posterior approach. And for a laminectomy, the goal is to make a cut here, unroof the spinal cord, and then put screws in to stabilize it and fuse the spine into a stable position. So the surgery begins by making an incision in the back of the neck. So this is a posteriorly based approach. Once we make an incision in the back of the neck, we expose all the lamina. So we basically expose all the bone here. Once we expose the bone very, very carefully with a high-speed burr, almost like a dental burr, we then make a line there, and we gently remove the entire lamina. So here you'll see we've used a burr to kind of score each side of the lamina. Once you score each side of the lamina, the entire piece can then be removed. And here you can see that after the bone has been removed, you can actually see the spinal cord. Now this isn't actually the cord swims in fluid, and that fluid is covered by a thin sac of stenosis saran wrap. So what you're seeing here is you're seeing what's called the dura, which is the covering to the cord. Right underneath that is spinal fluid and then the spinal cord. But for all intents and purposes, this is basically showing you how the kind of dura expands and how the cord now actually has space where it didn't have space before. We then drill little holes on each side of what's called the lateral mass. So this is the lateral mass, which is the area of bone that we actually put the screw in. So it's called the lateral mass screw. So we drill little holes, and here you can see the holes that are kind of drilled into the lateral mass, and then we place a lateral mass screw into the hole. So the screw is placed from the back to the front into the lateral mass. And I'll show you a picture of a lateral mass screw here. So it's a tiny little screw that's about that big. And that screw has a little tulip head on top. And you see that little miniature tulip head is where a rod then sits. So once we put the screw in, the rod sits inside like that. And then a little end cap goes on, and that basically connects all the screws for the fusion. So here's a good look at it. So this is a really nice kind of plastic model. This is the back of the skull. There's the side of my neck. And you can see in the back here, kind of a multi-level fusion. But here you can see the screws going into the lateral mass. Those are the screws I just showed you. And then in the back, there's a rod that then goes into the little tulip heads that's connected with an end cap. Usually we put bone graft on either side because a bone graft then allows everything to fuse. So this is an intraoperative picture here where you can see the lateral mass screws have been placed from back to front. You see the little tulip heads on. This is a case I did, I think several months ago, in a patient that had really, really severe deformity, bad cord compression. She's a realtor kind of that lives in West Marin, and actually had a terrific outcome. But it takes a little while to heal from this fusion. Here's a patient of mine. Before surgery, you can see he had pretty severe spinal cord compression, a little bit of deformity in the neck. So we unroofed the spinal cord here, and here you can actually see these little pointy things, which are called the spinous processes. On the x-ray, you can no longer see. These pointy things are kind of missing because we removed them with the laminectomy. And you can see the little lateral mass screws here going into lateral mass as well as the rod that's connecting them. Sometimes we'll also use the posterior approach to supplement an anterior approach. So these are called anterior-posterior surgeries. So we'll begin with the front and do what's called an anterior cervical fusion, go through the front of the neck. In the front, we may take the discs out, put cages in to reconstruct the spine. In the back, we would put in the screws to kind of fuse everything in place. This is a patient of mine who's a photographer and had pretty significant kind of congenital fusion, meaning his spine was kind of auto-fused in a certain position. He developed what's called kyphosis, which is a pitched forward posture. So we had to go to the front, take the discs out, restore his neck with an anterior cervical fusion from the front, and in the back we put in kind of rods and screws to stabilize him. Here's another patient I did a few, this was about a year ago. He lives in LA, but he had a chin on chest deformity. So he came in, chin completely on his chest. You can see kind of this severe, almost swan neck type deformity that he had in his neck. And we did a multi-level kind of stage 1 anterior cervical fusion from the front all the way from C3 to T2. So big operation to reconstruct his neck, put a plate on, and we put screws in the back. Here you can see the lateral mass screws as well as the rod. What are the risks and benefits of a cervical laminectomy and fusion? Let's talk about the benefits. Unfortunately, this is usually done for myelopathy, which, as I said, are symptoms related to cord compression. When there's myelopathy, I usually tell patients the purpose of surgery is to stabilize the condition, not necessarily to make you better. That being said, some patients do get a little bit of improvement in their myelopathic symptoms, such as fine motor skills, balance, strength, etc. But again, this is really to stabilize the condition. What are the risks of surgery? Number one, when we're taking the pressure off the spinal cord, there is a risk of spinal cord injury. Statistically, that's less than 1 in 1,000. We're watching the spinal cord the whole time. Typically, there's somebody in the room doing neurological monitoring. So they're putting little kind of leads and sensors in your arms to actually map the spinal cord and watch it while we're operating. Next is a dural tear, which is a tear in the covering the spinal cord. So again, the spinal cord is swimming in fluid. That fluid's covered by a thin sac. And I showed you that kind of sac before. That's a very, very thin layer. If the spur is scarred to it, as we remove the spur and the lamina from the back, the sac could tear. If a sac tears, it's not a big deal. We repair it, usually with a suture or some glue. This sits you upright for a day or two, just let the tear heal. It delays the recovery. It doesn't change the ultimate outcome of surgery. The next kind of intraoperative risk is we're putting in hardware, right? So we're putting in these screws, and these screws have to go in the right place. They can be near a spinal cord, a nerve, a blood vessel. We use our experience, x-ray guidance, neurological monitoring. Despite our best efforts, if a screw is causing irritation and causing a problem, we have to come back to revise it. That's exceedingly unusual. I can think in the last 15 years that's happened once, but it happens to you, it's 100%, so it can happen. Long-term after surgery, chance of infection, less than 1% typically. Chance you don't fuse. We're usually using very powerful bone-growing substances which allow the bone to fuse, so that's, I would say, less than 5%. Obviously, when we do a fusion, it does stiffen you a little bit. You're taking away the motion segment. My preference is not to do a laminectomy and fusion if I don't have to. Usually I'm doing a laminoplasty. I have another video on that. But if I have to do a laminectomy fusion, you definitely lose some motion. But it's really important to remember that 50% of the cervical range of motion comes from C1, C2. And also at the OC junction, which is the base of the skull in C1. And usually we're not fusing C1-2 for a posterior laminectomy and fusion. So the occiput is the base of the skull, which is here. C1 is here. So even if you were to fuse the entire spine down here, you can still have 50% of kind of flexion extension, which is nodding up and down. And C1, C2 is this kind of C1 bone, C2 bone, and that allows you to have rotation. That's 50% of your rotation. So you can still do 50% of normal there and there, even if you were to fuse everything from C2 to below. So a lot of patients think they're going to be like a stiff robot, but that's really not the case. You're not going to be a stiff robot. You'll have motion at the occiput C1 and the C1, C2 junction. Long term, there is a chance, because you've fused the segment, that you can break down above and below. We call that adjacent level degeneration. There is some literature surrounding that. Typically, that's about 3% per year. So maybe at 10 years, there's a 30% chance that you might develop a problem above the fusion, up at C2-3 or below. Typically, we're fusing to T1, T2, which is the upper thoracic spine. And that also kind of depends on the alignment of your neck, etc. But adjacent level degeneration is a real issue. It is something you can talk to your surgeon about. One of the biggest risks from this surgery is something called a C5 palsy. So what happens is when we do the decompression and the laminectomy, we basically make two troughs, we unroof the whole spinal cord, and because of that freedom, the spinal cord floats back. Well, these are the little nerves in the front, and these little nerves, as the spinal cord floats back, the nerve can get tugged on. It turns out the shortest nerve is a C5 nerve, and so there is something called a C5 palsy. That can happen anywhere from 5 to 10% of the time. And in fact, it can even happen with surgery from the front. But basically, a C5 palsy is when that nerve stretches. So the C5 nerve does two things. One is gives sensation to the shoulder, and it also gives strength to what's called the deltoid muscle, which allows you to do this and allows you to actually lift your arm to eat. So a C5 palsy, there's certain strategies that we can take to try to prevent that. And these are surgical strategies you can talk to your surgeon about. And sometimes we try to make an opening for the C5 nerve, or we try to make the laminectomy not quite as wide. But even in those situations, at best, again, maybe a 3 to 5% of a C5 palsy, that nerve, if it gets tugged on because the cord floats back, you can get pretty profound weakness in the shoulder. It almost always resolves. It can take a long time. I've seen them in my patients last sometimes up to 6 months to a year. Thankfully, most get better in the first 3 months. There's really not much to do about a C5 palsy. It almost always does get better, but it can be pretty scary because if it's a dense, very severe C5 palsy, patient can't move their arm up and down because the C5 nerve is stretched. Again, that's a very rare occurrence, but it can be pretty alarming when you see it, but almost always gets better. It's important to do what's called passive range of motion to the shoulder, lifting your arm up with your good arm to the bad arm to allow that shoulder not to get frozen. So that is something to look out for, which is a C5 palsy. A posterior laminectomy fusion surgery usually takes me about an hour and a half to 2 hours to do. The hospital stay is usually 2 to 3 days, and mostly it's because of neck pain. I require my patients to wear a hard cervical collar for 6 weeks. So this is just a type of hard cervical collar, and I'll put it on. Kind of looks like that. So the hard cervical collar basically prevents you from doing a lot of up, down, or right, left. And this is to keep the soft tissues in place and to also let the bones heal and fuse. And again, that's for about 6 weeks. I typically start physical therapy at around 8 to 12 weeks, depending on how a patient's progressing. They're out of the collar at 6 weeks. I usually let them drive once they're off narcotics, which is after 2 to 3 weeks. And then full fusion, which is healing of the bone, takes about 6 months to a year. So we'll usually follow with serial x-rays to see how a patient's healing, and they're usually fused at 1 year. We don't really see the ultimate outcome of surgery, the improvement of myelopathy, until about 1 to 2 years because the cord takes a long time to heal. But ultimately, we know that that cord is safe and free. So there you have a good overview on cervical laminectomy and fusion. It is a great option for cervical myelopathy or cord compression. You'll have to talk to your surgeon to see if it's right for you. Thanks for watching. Don't forget to click the subscribe and like button below and put some comments in the comment box below.